that we are on the ancestral lands of the Coast Salish, Duwamish, Stillaguamish, and Suquamish people who have resided on and stewarded this land since time immemorial and who are still here. And so on that note, I am so excited to welcome our grand round speakers this morning, Dr. Alyssa Colwell and Dr. Megan Cohen, both from OHSU. And the title of their presentation is Abortion Access, Crucial for Reducing Disparities in Maternal Mortality. Dr. Colwell is an assistant professor and complex family planning specialist at OHSU. She trained at Penn and completed complex family planning fellowship at OHSU. And during that time, she completed an RCT of opioid analgesia for medication abortion, which was published in the Green Journal. She currently serves as complex family planning clinical lead and director of the Ryan Residency Training Program at OHSU. And Alyssa has been honored with multiple teaching awards and has a reputation as a truly outstanding educator. And Dr. Megan Cohen and I have a special bond because we overlapped for a year of residency at OHSU. And we were also neighbors, and we also share a passion for global health. After completing residency at OHSU, Megan was recruited to Hopkins to be their first global health fellow in collaboration with JPIGO, which is a globally renowned nonprofit that works with governments to improve health outcomes, specifically in women's reproductive health. She then went back to OHSU to complete complex family planning fellowship and is currently in her second year of fellowship. Dr. Cohen will be returning to Emory, which is her med school alma mater, to join the complex family planning faculty there, as well as serve as Planned Parenthood Southeast medical director. And I was just imagining before we started the session that given the state of abortion legislation in this country, that could prove to be a very kind of interesting new position. So thank you so much, Drs. Colwell and Cohen, for presenting today. It's really great to see both of you.
Okay, sorry. Thank you so much. Is everybody able to see the regular PowerPoint? Perfect. Okay. Well, thank you so much, Dr. Harrington. So great to see you, and good morning, everyone. We are so happy to be here. Thank you for having us today. I'm Dr. Megan Cohen. I have Dr. Alyssa Colwell here with me, and we are presenting Abortion Access, Crucial for Reducing Disparities in Maternal Mortality. And so neither of us have any financial disclosures. However, we are both abortion providers. And I wanted to disclose that I'm also a signatory to the Amici Curiae brief that is arguing for maintaining abortion access in the Supreme Court case Dobbs v. Jackson, which we will discuss later on in this talk. So for our objectives today, we want to review abortion epidemiology, including who has abortions, when in pregnancy are abortions performed, and how safe are abortions. We will then review the national legislative environment regarding abortion and how rapidly evolving state abortion laws are threatening access. We will then discuss the implications of these restrictive abortion laws for patients and the effect on maternal and reproductive health. And finally, we will review what these impending abortion restrictions mean for our health systems in the Pacific Northwest and what we in Oregon are doing to help plan for an anticipated surge in demand.
We wanted to start this presentation with this slide because everybody loves someone who's had an abortion. Abortion is incredibly common. In fact, 1 in 4 women will have an abortion by the age of 45. Abortion access is essential for reproductive justice. Reproductive justice is a concept developed by a group of Black women in the 90s, which is the human right to maintain personal bodily autonomy, to have children, to not have children, and to parent the children we have in safe and sustainable communities. I want to take a moment to acknowledge that any person capable of pregnancy may need abortion care, including trans or gender non-binary individuals with the uterus. Whenever possible, we will try to use non-gendered inclusive language, but have preserved gendered language throughout the presentation when it is a direct citation. All types of individuals seek abortion throughout their lifetimes. 1/5 of all pregnancies will result in abortion. We know that abortion patients are comprised of all religions, races, ages, and incomes. 60% of people seeking abortion already have a child. Medication is used about 50% of the time to interrupt a pregnancy as of 2021 data, and may continue to grow in the setting of COVID, telehealth expansion, and more restrictions accessing abortion care. It is important to note that half of patients seeking abortion use contraception in the month prior. Most abortions occur early in pregnancy, as demonstrated by the pie graph. Roughly 90% of abortions are performed in the first trimester. This is important because the 6-week ban that is in place in Texas has made almost all abortions illegal. Most people don't even recognize that they're pregnant by 6 weeks, let alone have the ability to schedule an appointment, get childcare, obtain funds for an abortion, and arrange work coverage in such a short period of time to obtain a safe and legal abortion in the state of Texas today. This graph also highlights that abortions over 20 weeks have a delayed recognition of pregnancy, have difficulty securing transportation or financial means to pay for an abortion, and have delays in referrals or insurance coverage. Some patients receive a devastating diagnosis of a fetal anomaly at their 20-week anatomy scan and make the heartbreaking decision to end a pregnancy at that time. Additionally, most severe maternal conditions aren't discovered until later in pregnancy, at which time continuing a pregnancy could be extremely morbid or result in death.
What we know is that abortion overall is a very safe procedure. On this chart, you can see various conditions on the left and their associated mortality rates and deaths per 100,000 on the right. They are arranged from fewest deaths or most safe conditions starting at the top to least safe at the bottom. And we can see that first trimester abortion is safer than experiencing a miscarriage, running a marathon, or undergoing plastic surgery. And while the risk of abortion-related complications is slightly lower earlier in pregnancy, the risk of dying from abortion in any trimester is 5 to 100 times lower than the risk of dying from childbirth in the United States. In fact, the 2018 report from the National Academies of Sciences, Engineering, and Medicine concluded that all forms of abortion, including medication, aspiration, dilation, evacuation, and second trimester medical induction, are safe, and that the only factors that are decreasing safety are those which serve to decrease access. Thus, despite what some legislators and anti-choice advocates may claim, studies show no increase in preterm delivery, miscarriage, or infertility related to abortion, no link between abortion and adverse mental health outcomes, and studies show that abortion may actually be protective towards the health of a subsequent pregnancy in adolescence. Furthermore, abortion restrictions do not decrease rates of abortion. So even if certain states outlaw abortion, they're not going to stop people from seeking abortion. There's an abundance of national and global data that supports this. On this slide, we have global data on abortion rates that is compiled by the Guttmacher Institution, comparing countries with restrictive abortion laws to countries without restrictive abortion laws. In dark green at the top, we note that 37 per 1,000 women aged 15 to 44 seek abortions in countries where abortion is restricted, where it's either prohibited altogether or permitted only to save a woman's life. Compared to this, in light green, 34 per 1,000 women seek abortions in countries where abortion is available without restriction. So what's notable is that the abortion rates are essentially the same, if not slightly lower, for countries where abortion is unrestricted compared to countries where abortion is highly restricted. And in fact, abortion restrictions only serve to increase the proportion of unsafe abortions. The World Health Organization defines a safe abortion as any modern day evidence-based procedure, such as evidence-based medication abortion or procedural abortion, that is performed under hygienic conditions by a trained provider. This is depicted by the green color on this slide. Unsafe abortions are further categorized as less safe abortions, depicted in blue, and least safe abortions, depicted in red. Less safe abortions include use of safe methods that are performed not under the direction of trained providers, or alternatively, if trained providers are performing outdated procedures such as sharp dilation and curettage. Finally, least safe abortions, again, that are depicted in red here, include ingestion of caustic substances or herbs, use of physical trauma, or insertion of sharp objects to try to induce abortion, like the provocative imagery of coat hangers. So to orient you to the rest of the slide, on the y-axis, we have countries grouped by abortion restrictions from most restrictive at the top to least restrictive at the bottom. And on the x-axis, we have proportion of safe or unsafe abortions within those groups. As we have discussed, we know that the overall rate of abortions does not differ by restrictiveness of a country's abortion laws. Instead, as shown here, as countries increase their abortion restrictions, the proportion of safe abortions in green decreases from about 90% for countries with no abortion restrictions to 25% for countries with the most restrictive laws. And concomitantly, the proportions of less safe and least safe abortions increase. So what is the legislative atmosphere like in the United States? As we know, this is rapidly changing, but I want to first ground us in some of the landmark federal cases and laws that currently shape the legality of abortion in the United States. So as we all know, currently the constitutional right to abortion is affirmed by Roe v. Wade, which is the 1973 Supreme Court decision, which ruled that due to the due process clause of the 14th Amendment, that there is a right to privacy that protects abortion rights. This ensured that abortion was protected like any other medical decision made in consultation with one's medical provider. Then, in 1992, the Supreme Court ruled on the Planned Parenthood v. Casey case, which was a decision that clarified protections afforded in Roe v. Wade. This decision imposed the no undue burden prior to viability clause, which means that states cannot enact legislation which severely restricts access to abortion prior to viability, barring any significant lethal fetal anomalies. While recently this has been very challenged, states have been skirting this law and stretching the definition of undue burden for years, as we will discuss shortly. And we know that there are many other laws that shape the federal protections and federal restrictions for abortion, but we wanted to focus on these two Supreme Court decisions. I also wanted to highlight the federal restrictions on abortion, which is largely comprised of the Hyde Amendment. The Hyde Amendment is a racist policy rider that's been passed in all federal appropriation bills since 1976. While there was a valiant attempt to try to pass a bill without the Hyde Amendment in this current legislation, that is likely to fail. And the Hyde Amendment prohibits federal funds from covering abortion. So there's no federal coverage for patients enrolled in Medicare, Medicaid, or CHIP. It restricts abortion access for military personnel and veterans. It restricts access to patients in the Indian Health Service and for individuals serving in Peace Corps. This legislation disproportionately affects Black, Latinx, and low-income individuals who are more likely to be enrolled in publicly financed insurance programs, as well as Indigenous patients seeking care in the Indian Health Service. Specifically, the amendment affects 34 states and the District of Columbia, which do not have separate state public funding for abortion care. It's estimated that this leaves about 7.8 million people without access to abortion coverage. And because of the amendment, an estimated 1 in 4 patients affected by the policy are forced to continue pregnancy. And we know when women or patients are forced to continue a pregnancy, there are really significant socioeconomic repercussions. I'm sure that many of you in this audience have heard of the Turnaway study. This landmark study asked the question, what happens to people who are denied a wanted abortion because they were slightly over the gestational age limits of their facility, compared to people who were near the term limits of the facility, but were still able to have their desired abortion? And the study found that when people seeking abortion were denied their desired abortion, they were more likely to live in poverty for up to 4 years after the denial, to be unemployed, to rely on public assistance, to parent alone, to have contact with an abusive partner. Their children were more likely to have lower mean child development scores and to have children living in poverty, thus leading to possible intergenerational effects. While some people may underestimate the impact of socioeconomic outcomes, these differences directly affect social determinants of health, serving to exacerbate disparities in reproductive health outcomes, such as maternal mortality, which we know disproportionately affects women of color. In fact, 2 of the patients followed in the study who were denied abortion did ultimately go on to die from pregnancy morbidities, versus no patients in the group who obtained their desired abortions.
Monica Simpson, the executive director of Sister Song Women of Color Reproductive Justice Collective, points out in this timely editorial in the New York Times published on April 11th of this year that to be pro-choice, you must have the privilege to have choices. She points out that as devastating as the fall of Roe would be, it's important to keep in mind that Roe never fully protected Black women or poor women or so many others in this country. That's because Roe ensured the right to abortion without ensuring that people could actually get an abortion. She further states that people seeking an abortion in America must consider, do I have the money? How far is the nearest clinic? And can I get there? Can I take off work? Will I be safe walking into the clinic? For more privileged people, these questions are rarely a deterrent. But for many women of color and poor people, these are major obstacles. And that's how white supremacy works. On top of that, women of color in states with restrictive abortion laws often have limited access to healthcare generally and a lack of choices for effective birth control. Schools often have ineffective or inadequate sex education. And in almost every aspect of reproductive health, women of color today are more likely to experience racism and discrimination in the US healthcare system. Black women have poorer health outcomes compared to white women and are 3 times as likely to die of pregnancy-related causes. Monica mentions disparities in access to abortion based on state location. This bar graph acts as a heat map to show the various potential state-level restrictions, ranging from states with the most restrictions on top to the least restrictions. And you can see Oregon here is denoted by the blue arrow and Washington by the purple arrow are at the bottom, 2 of the states with the fewest or no state-level abortion bans. Washington's only law about abortion is that abortion may be performed at or after viability only if the patient's life or health is endangered. These bans, known as trap laws or targeted regulation on abortion providers, range from ultrasound requirements, waiting periods, mandatory counseling that's often inaccurate, and physician and hospital requirements. A lot of these laws pass posing as a means to increase safety, when in fact they actually make abortion less safe by serving to decrease access and increase barriers for patients. There are states that only allow physicians to perform abortions, and we know that advanced practitioners can safely perform abortions and fill essential gaps in resource-limited settings. While Roe theoretically upholds the right to abortion federally, the reality is that in many parts of the country, abortion access is already severely limited and restricted. And as you can see from this graph, the protections of Roe v. Wade have been slowly chipped away since it was decided back in 1973, with over 1,300 abortion restrictions enacted. More importantly, in 2021, this was the worst year for abortion restrictions, with over 117 being enacted. Historically, the federal courts have been a safe haven against most trap laws proposed. However, since 2016, many federal judges that are staunchly pro-life have been appointed in record high numbers, along with 3 Supreme Court judges who have professed their pro-life beliefs in an effort to weaken the protections upheld by Roe. And on to Texas SB 8. It's really hard to hear about this law, which is a near total abortion ban that went into effect September 1st of 2021. This law has made abortion illegal if cardiac activity is detected, which typically occurs around 6 weeks. Again, this is often before most patients even discover that they're pregnant. 85% of all abortions in Texas occurred prior to 6 weeks, prior to SB 8 being enacted. There is a provision for medical emergency, but as we'll discuss later, the vagueness of this provision can make it difficult to know when it is legal to act on behalf of a medical emergency. There's no provision for rape or incest. And what makes this law innovative is that Texas SB 8 is the first abortion restriction to rely on enforcement by private individuals through civil lawsuits, rather than by the government through criminal or civil enforcement. This act establishes a system in which any member of the public can sue anyone who performs or aids and abets an illegal abortion for a minimum of $10,000 in statutory damages. This could be an abortion provider, a counselor, or a scheduler who works at the clinic, or even an Uber driver who dropped a patient off at the clinic. It also specifically precludes courts from reimbursing defendants' attorneys' fees. The Supreme Court declined to rule, which allowed this law to stay in effect, even though the ban was unconstitutional. And Texas SB 4 became effective in December of 2021. This now restricts medication abortion after 7 weeks, even though medication abortion is known to be safe up to 11 weeks gestation. State enforced, this law specifically was written to highlight the dangerous and inaccurate concerns about the safety of medication abortion after 7 weeks, which is false. It restricts provision by mail, which is designed to limit self-managed abortion, and violations are steep, where you can be subjected to jail time for up to 2 years and $10,000. As I'm sure many of you have heard, the Supreme Court heard oral arguments for Dobbs v. Jackson Women's Health Organization on December 1st, 2021. This is Mississippi's law banning abortion after 15 weeks. And while there are provisions for risk to life and severe fetal anomaly, they are vague and difficult to apply. This law is specifically designed to overturn Roe v. Wade and demolish the federal protections of abortion in the United States. Experts postulate that SCOTUS is likely to uphold the ban. It is uncertain if they will completely overturn Roe, which would mean a loss of federal protections of abortion, or remove the viability clause, which would allow states to arbitrarily restrict abortion prior to viability. Though rare, a 15-week ban is significant in that most fetal anomalies or maternal conditions are unlikely to be identified at this stage of pregnancy, and people seeking abortion care after 15 weeks are often our most vulnerable patients. And many other states are following suit. Our neighbors to the east in Idaho have attempted to pass a Texas-style SB 8 copycat law entitled Idaho Ban SB 1308, which is a law that relies on civil enforcement, essentially making abortion illegal in the state of Idaho. It allows family members of a preborn child to sue abortion providers a minimum award of $20,000 plus legal fees up to 4 years after an abortion occurs. There are exceptions for life endangerment, severe health conditions, rape, and incest, although the vagueness of these laws make it challenging to know when it's safe to legally apply these exceptions. Signed by Governor Brad Little in March, this law was scheduled to go into effect on April 22nd of this year. However, there is currently a temporary stay in place, which means this law could go into effect at any time.
So this begs a very real question. What is going to happen to abortion in the United States if Roe v. Wade is overturned? On this slide, you can see the 26 states in orange that are certain or likely to completely ban abortion per the Guttmacher Institute if this were to occur. As of the most recent data, 13 states have trigger abortion legislation on the books, meaning that all abortion would immediately be banned in those states if and when Roe is projected to fall in June. Again, this is a rapidly evolving situation as more and more states race to pass legislation after the Supreme Court signaled the likelihood of overturning Roe v. Wade in oral arguments for Dobbs v. Jackson. And just in March, Wyoming became the 13th state to pass one of these trigger bans. So what does this really mean for us, for our patients, and really for anyone who can become pregnant or loves anybody who can become pregnant? I want to pause a moment and consider this image. This is a memorial to Savita Halappanavar, who died in 2012 of complications related to an inevitable miscarriage. Halappanavar, a 31-year-old dentist, presented to an Irish hospital with ruptured membranes prior to viability and was hospitalized. Abortion at the time was illegal in Ireland except to save someone's life. Despite developing an infection, her doctors delayed performing a life-saving dilation and evacuation as there was still a fetal heartbeat. And Savita ultimately died due to overwhelming infection and sepsis. This is only one story, but we know that there have been other patients like Savita. This is not a hypothetical situation. We have already heard from our colleagues on the ground in Texas of similar situations, where providers feared inducing patients in similar circumstances, given the vagaries of the SB8 wording and difficulty determining what constitutes a medical emergency. As we all know, our pregnant patients are usually young and healthy and can compensate until they are unable to. So by the time that we have diagnosed a life-threatening emergency, it may be too late to save their lives. I just want to emphasize, this is a preventable maternal mortality. She should be alive today. And what this story really highlights is that even though abortion restrictions are often framed as protections for patients, instead, they lead to delays in care. This can include obstruction to management of miscarriage, early pregnancy loss, and diagnosis of ectopic pregnancy, which we've also seen related to Texas SB8, or like Savita, delays in managing infection or hemorrhage, resulting in potentially catastrophic health outcomes, including maternal mortality. Abortion restrictions will also likely lead to delays in patients presenting to care due to fear of retribution or criminalization of the situation, further placing their health at jeopardy. And again, criminalization is not a hypothetical situation. Abortion restrictions, particularly when tied to fetal personhood laws, are already leading to criminalization of abortion and miscarriage in the United States. Just imagine being in the midst of a medical complication, likely already an incredibly emotionally distressing scenario, and being arrested. Well, this is exactly what has happened to pregnant people in the United States. For those who are not aware, this slide depicts headlines and pictures related to the prosecution of Brittany Pula, who was a 21-year-old Indigenous woman in Oklahoma. Brittany suffered a miscarriage at 17 weeks, and prosecutors argued that her use of methamphetamine and marijuana caused her miscarriage. She was then convicted of manslaughter and sentenced to 4 years in prison. Again, these prosecutions disproportionately impact patients of color and other marginalized populations who are inequitably targeted and often do not have the resources to defend themselves. This slide depicts a more recent example. Lizelle Herrera is a 26-year-old arrested in Texas on April 7th, 2022, accused of, quote, causing the death of an individual by self-induced abortion. She was held in jail on $500,000 bond until there was a public outcry due to mass media attention, and the DA subsequently dropped charges. Lizelle was arrested even though Texas law typically exempts a pregnant person from being charged with murder or any lesser homicide charge for an abortion, as state laws instead usually target the provider. Dana Sussman with the National Advocates for Pregnant Women said that because of the recent anti-abortion laws in Texas, Herrera's arrest was, quote, expected, even if unconstitutional. She stated, what the laws in Texas and elsewhere claim to be doing is criminalizing the provision of certain types of care. But what we know is the reality from our cases and from what we've seen in the past and what we're currently seeing is that the people who actually experience pregnancy will also face criminalization. But more commonly, the fall of Roe v. Wade will mean severely restricted access for patients from these states, leading patients to cross state lines and travel drastically increased distances to reach their nearest abortion providers. This slide depicts the average distance to nearest abortion provider by county currently, seen on the left, and the projected change in anticipation of 22 expected state bans and restrictions that's depicted on the right. The scale ranges from 0 miles to nearest abortion provider in light green, to 400 or more miles to nearest abortion provider in black. What is really striking is the drastic increase in driving distances to nearest abortion providers expected in the South, Southwest, and Midwest, as well as Utah and Idaho. The nationwide average estimated travel distance for someone seeking abortion is anticipated to increase 5 times, from 25 to 125 miles. Of course, this will disproportionately impact patients who already have barriers in care access, including low-income patients and those who have financial or childcare barriers to travel. This is also going to strain local health systems like we are already seeing in Texas border states and beyond, as the states immediately bordering Texas race to pass their own restrictive abortion laws. And if and when abortion access is further restricted in Idaho and Utah, we anticipate an influx of people seeking needed abortions in both Oregon and Washington.
And so what does this mean for us here in the Pacific Northwest? Well, our state mottos represent some serious positivity. Oregon embodying a female identity and independence with the motto, "She flies with her own wings," and Washington state motto, El Kai, a Chinook word meaning into the future. I'm going to just brag for a minute about Oregon, our state, which is considered an oasis compared to much of the nation. There's broad, progressive, comprehensive reproductive health protections and broad, comprehensive contraceptive coverage. Any pregnant individual can obtain insurance coverage, and the expansion of Medicaid in 2015 expanded coverage for transgender and gender affirming care. And recently, Oregon has passed $15 million fund to cover abortion travel costs for patients traveling to the state to receive abortions and the providers performing the procedure. And Washington is taking action too. In March, Governor Jay Inslee signed legislation H 1851, which expanded abortion protections. This law amends the state's statutory protections for abortion, which were enacted more than 30 years ago and applied only to women, to now include transgender individuals by adding gender neutral language. The law also codifies the authority of health clinicians, such as physician's assistants and advanced practice nurses, to provide abortion care. The law also prohibits the state of Washington from criminalizing any pregnancy outcomes and prohibits the state from penalizing people for assisting pregnant individuals who are seeking an abortion, basically protecting individuals in the state of Washington from a copycat law that was enacted in Texas. And this law is scheduled to go into effect in June. And if Roe falls, we anticipate abortion will become illegal in 26 states. This total ban would mean Washington could see up to a 385% increase in individuals seeking abortion care, which equates to roughly 500,000 individuals, mainly from Idaho and Montana. As an example, an Idaho resident today needs to travel a median distance of 21 miles one way to the nearest abortion provider. That's going to increase to 250 miles one way, which is over an 1,100% increase. If a 15-week ban falls into place, there's an expected doubling of projected cases for Washington alone. And so how can we address this impending surge and increase access when health systems are already stretched so thin? It's been a rough couple of years in healthcare with COVID, with losing staff, and we're trying to find ways to address this impending increase in volume with less resources than what we've had in previous years. And so at OHSU, we're taking a multi-pronged approach to increasing our service provision. We have engaged key stakeholders at all levels in an attempt to allocate resources for the projected volume increases as early as this summer. We've identified multiple providers within our OBGYN division who are interested in providing medical and abortion and aspiration abortion services outside of our complex family planning division. And while COVID has had a ton of negative effects that I don't need to go into today, it did have one positive outcome, and that it forced medicine into the world of technology by increasing utilization of telemedicine services. And so in having this service, we've been able to convert almost all of our pre-op and post-op visits to telemedicine appointments, which has freed up in-person appointments for patients requiring in-office care. We're also working to expand telemedicine services for medical abortion, including telemedicine follow-up with home pregnancy tests instead of requiring an in-person visit. We have great relationship with our community partners and clinics that provide abortion and have streamlined the referral process between our two clinics for patients that require either a higher level of care that need to come to us or patients that are low risk and can go to our community clinics. Our personal clinic at OHSU is now recognized as a National Abortion Federation Clinic, or NAF clinic, which connects individuals seeking abortion to clinics that provide them and offers financial assistance. OHSU also was able to develop a cash package for abortion services for patients who don't have insurance coverage for abortion. And this is mainly to serve patients coming from out of state that need to travel for care. Currently, abortion care at OHSU is provided in a variety of settings. So in our outpatient clinic with the option for local, oral, or IV sedation, as well as our outpatient surgery center and our main OR. Family planning has protected OR block time 1.5 days per week, so we can guarantee timely access to care for patients risking out of clinic-based services. Our ability to expand our OR block time right now, though, is severely limited given hospital constraints. And so we're working to expand our clinic IV sedation services. We also have the ability to provide D&E services on labor and delivery, especially in emergent settings. And we have a contingency plan to reallocate services for our providers helping patients undergoing miscarriage or those seeking tubal ligation procedures should we be unable to meet the demand for abortion services as the volume rises. And finally, none of this planning would be possible without the recent creation of a family planning clinical lead position supported by our chair that has provided protected academic time devoted to addressing these issues.
So how else can we as a specialty and as individuals take action to ensure that abortion rights are protected and people seeking abortions can get the safe healthcare that they deserve? First, I want to put a plug in for voting. And this includes not only in federal elections, but in state and local elections as well, as we know so many abortion restrictions or protections start at the local level. We also crucially need to help financially support those who are helping to facilitate abortion access. This includes supporting national and local abortion funds that have been so instrumental in helping patients get to care. I can't even speak highly enough about our local abortion fund that has really helped with transportation for our patients, for assisting in resources for our patients, and we've really tried to partner with them more so recently, as many of our patients in the time of COVID are coming with significant needs for resources and transportation. We also can help support and partner with reproductive justice and community groups who have been the boots on the ground, helping individuals with access barriers obtain care for years. Just like we were saying, Roe hasn't protected many communities or assured access to care for many communities, including the most marginalized communities, for many years now. We also need to help keep our independent abortion clinics afloat, as the majority of all abortion care nationally is performed in the independent abortion clinic network. And there are also several federal initiatives that we can advocate for. Unfortunately, in this recent Congress, all of these were attempted to be passed and have unfortunately failed. But the first is to support the Women's Health Protection Act, which could enshrine abortion rights into federal law. This act was actually passed during the last House session, but it failed to pass a procedural vote in the Senate by a 48-46 vote. However, we anticipate that the act will be reintroduced in the future. Additionally, we can continue to voice opposition to the Hyde Amendment and try to help support the Equal Access to Abortion Coverage and Health Insurance Act, or the EACH Act, which essentially would negate the Hyde Amendment at the federal level and ensure that all federally funded insurance policies would cover abortion care. As OBGYNs and providers, we can also keep advocating for the complete removal of REMS for mifepristone to allow unrestricted access to prescribing and dispensing this incredibly safe medication, thereby even further increasing access to medication abortion. And for those who want to increase their advocacy, I would encourage you all to refer to the Physicians for Reproductive Health website for resources and opportunities to get involved, which I know some of you have already done. So in conclusion, hopefully after our talk, you will have seen that abortion is common and safe. It is routine, essential healthcare. Hopefully we'll see that abortion is essential to decreasing health disparities in maternal morbidity and mortality. The US, unfortunately, has the worst maternal mortality rate of all industrialized countries, and we only anticipate this to worsen should abortion become further restricted. As we discussed, abortion is at severe risk of being restricted federally. And for Oregon and Washington, this will mean more referrals and the need to deliver innovative models of care to increase access. Nationally, it means that based on your zip code, abortion may become illegal and inaccessible, and pregnancy overall will become less safe. So we wanted to leave lots of time for us to have discussions, since I know kind of our situations align, and we're hoping to share tips and tricks between both us and what y'all are doing in Washington. But we just wanted to acknowledge OHSU, our Division of Family Planning, and give a shout out to our webpage, where we also have our contact information if for any reason we do need to do mutual referrals from Oregon to Washington.
And while we have much to despair, we leave you with this inspiring quote from Monica Simpson. It is our duty to hold everyone accountable at every level, every day, because our lives depend on it, and because Roe might soon be gone. But we can imagine a better world, one at which we have not just the minimum, but stand at the mountaintop, true reproductive justice. Thank you.
Thanks, everyone.
Thank you so much. That was really excellent and wonderful to end with that quote as well. While folks are getting on, are putting their questions into the chat, I had a couple questions for you both. And Alyssa, you mentioned that, you know, I know you're the clinical lead, and I'm sure that you have a lot of partners in this, but that you were engaging a variety of stakeholders. And I wasn't sure, like, as you kind of plan for a surge in clinical volume. And I was wondering if you could comment a bit more on, like, at what level are those stakeholders? Are those like state resources? Are those institutional resources? Are those departmental resources? If you could just kind of speak to which stakeholders and which resources, I think that would really, that would answer my question.
Yes, thank you, Liz. And just to orient to people who aren't familiar with our family planning division, there are 13 of us. So we are the largest family planning division in the nation. And so by no means is this a solo effort. Every single person within our division is working to engage somebody at our institution, in, you know, at the state level and at the national level, to really try to allocate resources as we anticipate this surge. You know, from a institution perspective, we've been speaking with, you know, our clinic, which in the last 6 months has had our main nurse manager has left. We've had a lot of different changes as far as leadership. And so while there has been a challenge just to adequately staff our clinic, the new people that have come into these roles, I think, are very inspired to really try to address this need that we're seeing. Part of our limitations is just, you know, we're trying to staff up. So our sedation clinic right now, the biggest limitation is that we don't have a nurse available to expand our sedation services. And so our clinic manager is very aware and is working to kind of expand and get somebody hired for that role, which is great. Besides our clinic, we have been engaged with, you know, even our call staff, our PAS staff that answer all of the phone calls for our clinic. We lost most of our PAS staff during COVID. And so we have now fully staffed PAS, so that as we anticipate more volume in calls, we are able to actually take those phone calls and not have there be a 30+ minute wait to speak to somebody on the phone. We've hired 2 care coordinators specifically for family planning. So 2 coordinators that are medical assistant trained, who sit and help with our coordination and make sure that we have OR availability, clinic availability. From a clinic level, we have then gone up to really talking at a hospital institution level. So we've talked with anesthesiologists, we've talked with OR staff, we've talked with, you know, people that make much bigger decisions than what my current standing is within the institution, to really show that this is going to be a significant need for us. We had a meeting with a GI physician last week to talk about, could we potentially utilize the endoscopy suite on days where they have low volume? So we're really trying to get creative to see how we can try to expand services. In addition, we have Maria Rodriguez, who is our policy expert, who works at the state level, and was one of the main people who was able to rally for this Oregon state fund for patients expecting to travel to Oregon to provide them some funding from a state level, really showing a statement that Oregon is committed to reproductive justice. And so if there's anybody at OHSU or within our state that will listen to us, we have been really trying to reach out. We have meetings with the emergency department to talk about how we can increase access there. So patients who get a new pregnancy diagnosis who maybe want to initiate an abortion at that level, we're trying to see if we can help allocate resources so that they don't necessarily need to be seen in clinic another day. And so that's everything that we've been trying to do in a very short 2-minute explanation.
Thank you so much. Well, the chat is getting very active now, as expected. Lots of thank yous. And then I did want to, Bonnie, I see your videos on. Would you want to just ask your question verbally?
I think Elizabeth Mix has a similar question. We've moved the needle for offering life-sustaining interventions for neonates down to 22 weeks. And we very thoughtfully tried to put it together so that MFM will offer termination or life-sustaining, but it's a very significant conversation. And I'm just wondering what, this is a nationwide move to 22 weeks. And I'm just wondering what your thoughts are of how this might have an influence in other states. And that's my question.
Yeah, that's a great question. In Oregon, for those of you that don't know, there is no gestational age limit. And so we are able to provide care for patients beyond 24, 25 weeks. We have a really great relationship with our fetal therapy program, one in which we work concomitantly to really try to help counsel patients who are seeking the decision to end a pregnancy, regardless of gestational age. And we also have an amazing NICU that is really supportive. This has taken years of team building in order to develop this relationship. And we really see, although rare that we get these cases, we are seeing them more frequently with patients that are being referred for significant fetal anomalies from all over the country, since the number of places that are able to legally care for these patients are decreasing. And so I think really, OHSU has been firm in support for these patients that do require termination beyond, what's considered viability in each individual situation.
It looks like Dr. Mix had a question specifically about our exceptional case review committee. And that's a really interesting topic. We had developed that to kind of consider these cases case by case, especially if there were not fetal lethal anomalies involved past viability. And we ultimately found that while helpful, in some cases that was a little bit of a barrier to care. And so we've been moving towards a model in which, again, with really great communication with our MFM colleagues, discussing who would be willing to provide KCL in some of these cases, we're moving to more of a model where if patients come with, very significant social issues or other considerations past viability, we just kind of have an internal team discussion, and we have some providers that we know would be open to providing KCL in such cases. And so we're ensuring that the teams involved will be feel comfortable with that care, but we are making it a little bit less formalized so that it is not acting as a barrier to having people seek care with us.
And Megan, could you, while we're on that topic, could you speak to, is that past sort of the, 26-week gestation, is that care happening on labor and delivery, and how have you built relationships around that care with your nursing staff?
I can actually take this question. Yeah, so that's a great question, Liz. And this has been years in the making. We have a core group of nurses that really see themselves as leaders in being able to provide comprehensive abortion care to our patients on labor and delivery that are having induction termination. We actually just met with them last week because, as you can imagine, our labor and delivery has had significant turnover in the last 2 years with COVID. And what we realized was that our nurses that are offering this care are really struggling with some of the resources that they need to onboard new nurses that are interested in providing this care, but resources have been lacking in the last 2 years. And what we realized is, we used to do a lot of in-services. There were opportunities for nurses to come to our clinics to see how we talk to patients. We would do values clarifications. And so we, having this meeting last week kind of as a check-in, which we do usually 1 or 2 times a year, really showed us that with this new influx of employees that we really need to further provide support again. So I think we're very lucky in that we live in a place where we have a lot of people who feel very strongly in support of these services, but it's really important to note that these services are really emotionally challenging and that other support needs to be there in order for them to, for our support group to continue to grow and thrive in these settings.
Some of it was actually born out of the nurses themselves who were coming to us saying, we offer these services for fetal therapy patients, but why aren't we offering services for other patients? And so we have had a little bit of a turnover, but also a bunch of new nurses coming in who are really wanting to help provide abortion care too, which I think has been really a great service for us.
Thank you. Sarah, I feel very powerful calling on you.
Thank you, Liz, for acknowledging me. And thank both of you so much for this really fantastic presentation. And I think that the similarities in our 2 states really create an opportunity for us to collaborate around this. And I think you raised a lot of the similar challenges that we face at the University of Washington and some similar kind of solutions that we've come up with, and also some new ones that I think that we could take or expand from things that we're already doing. And I've really appreciated our past conversations and this talk in terms of giving me some inspiration and ideas about ways that we can move forward. And I actually, one of the things that I'm motivated by with what you were just saying as well is that I also think that the turnover is a real opportunity for us to actually make participating in abortion care, whether it's in the clinic or in the operating room or on labor and delivery, one of the criteria that we're actually looking for new hires when it comes to staff nursing or MA. And I don't think that historically has been a criterion that we are kind of focused on. But I think we're, with the anticipated increase in volume that I expect we'll see, not just at our independent clinics where I am sitting currently, but also at the University of Washington, it's going to potentially be pretty critical for us to kind of keep that in mind. And so I think working with the people who are in charge of those hires, which is unfortunately not our department, that's like a hospital hire thing, is going to be really important for us to make sure that this care is able to be handled in hospital settings. So I just want to say, I really appreciate the work that you have done in Oregon, and I know that we already share patients between our 2 institutions, and I think that's going to only have to increase, but as well, really learning from the things that you've done that have been successful. And also, you talked about pride in your state and what you've done. And I actually feel a huge amount of pride for what we've accomplished in Washington State and at the University of Washington for being able to be, as reproductive health focused and forward as we are. And still, now is an opportunity where we're going to need to challenge ourselves because of the 300% volume increase that we're expecting to see. So I'm trying to look at this as an opportunity, not as something daunting. And so thank you very much.
Thanks, Sarah.
Yeah.
I had one other question. I was like kind of piggybacking on what Sarah is saying, but like your cash, the cash plan is really exciting to me to kind of think more about. Like it seems like such a, like a no-brainer, but I imagine that was really challenging to put together. And the patients that I'm thinking about, like from Idaho and Montana, that I'm like particularly worried about are folks who won't qualify for like a life endangerment situation to have their abortion paid for in their state in a hospital setting. Like not like I'm thinking about like not the folks with like liver failure who have an INR of 5, but the folks who won't really qualify for an outpatient setting. Like we take care of a lot of folks in Seattle at UW Medical Center who aren't a candidate for an outpatient abortion because of like really extremely elevated BMI, for example, that makes it too challenging in the outpatient setting, or they need a central line because of poor IV access. So something that's not really life-threatening for pregnancy, but like do you offer cash plan in your OR? And like, that just seems like something we need to be thinking about for people who need an OR abortion.
Yeah, we offer a cash price for medical abortion clinic, for aspiration procedure in the clinic, and then for an OR cash price. This was a monumental feat that I had relatively little to do with. This was Lisa Bayer's brainchild, and I think it took a couple of years in order to try to work that out, since most hospital-based care does not have a set price. And with the changes in coverage and yearly changes in insurance plans, those prices are constantly in flux. And actually, because it took so long for us to get a cash price, our medical abortion is actually the cheapest in the state, because it took so many years that when we set the price like 5 years ago, when we started this process, we actually are the lowest now and haven't really accounted for some of the increases in care. But those cash prices are really important for patients who otherwise can't seek care. Or can't get coverage if they're coming from out of state. The other thing that the cash price does is that to be eligible for some of the NAF funds or other funds, there has to be a cash price in order for those organizations to offer funding to patients. And so we felt the same way, Liz, that patients that were risking out of a clinic abortion were really not able to have any alternative option when they needed that increased care at a hospital-based setting. So this kind of eliminated that barrier.
And then we also offer a self-pay discount for people that need like a second try medical induction, because that we don't have a true cash price within our group, but there is a discounted price for individuals who aren't covered.
That's very inspiring, and something that I think we need to work on. And CN just put a comment in here that we do have some precedents for cash pricing for plastic surgery and REI, and then the challenge tends to be like breaking even for the medical center. Of course, my perspective is usually like, why do we have to break even? Why can't we just pay for the care? But obviously that's not going to be financially viable. So something definitely to think about. But anyway, I know we're 1 minute over the hour now. I just wanted to say thank you again, Megan and Alyssa, for this really wonderful presentation and discussion. We really appreciate your time, and it was great to see both of you.
Thank you so much.
Can you guys stay on just for a minute?
Yeah.
I was curious about, well, I think folks are falling off, but, you know,